Hello, everyone. It's great to see you all here today. And I am Joanne Milo, and I'd like to welcome you to our first T1D to 100 presentation on type 1 diabetes and aging. This talk aims to share insights from the research on the issues that affect those of us living with T1D longer than anyone had expected. Nothing you hear today is medical advice. Remember to always check with your healthcare providers regarding your own diabetes management as we explore and share knowledge that we hope will help all of you age gracefully and joyfully as possible. I'm very excited today to introduce you to Dr. Medha Munshi, who has been a researcher in gerontology and endocrinology for over 20 years, long before anyone really was talking about the issues we face as we live and age with type 1 diabetes. She is an associate professor of medicine at the Harvard Medical School, director of the Joslin Geriatric Diabetes Program, and founder of the International Geriatric Diabetes Society. And for our community, she was the first person to jump on the T1D to 100 advisory panel. Very, very excited about that. The primary focus of Dr. Munshi's clinical research is to identify the challenges faced by older individuals with diabetes, develop strategies to overcome these barriers, and improve clinical and functional outcomes, including the quality of life. What's so remarkable is her steady insistence on listening to the voices of our lived experiences. She really is interested in hearing from us. We're so honored to have Dr. Munshi share the work of this growing international research community. This is a photo of her 6th annual workshop held last week in Boston as a gathering of 50 influential researchers, healthcare professionals, long-term T1Ds, and the latest crop of fellows in her medical program. Their passion and their commitment to this field of research is just so breathtaking. My husband, Richard, and I had the opportunity to attend and participate. And I would guess the majority of the major researchers that focused on this area were in Boston that day, and it's very, very exciting. With that, I'm going to turn this over to Dr. Munshi, and she will enlighten you, and I hope you learn a lot tonight.
Well, thank you, Joanne, and what a privilege it is to be here. And if I could, I mean, looking at just the faces, I would love to hear from each one of you what is your story, but probably that we can do one at a time, in good time. But as Joanne said, that I'm a geriatrician and a diabetologist. She told me to tell you how I ended up here. Uh, these days, these young people, they had exactly know what they are going to do with their life. Not quite that way with me. Life took me the way it took me, and fortunately, I ended up where I am really fortunate to do what I do. I was an endocrinologist first, and just with the politics of the way things were, I ended up in geriatrics. I didn't have a whole lot of experience or exposure to geriatrics in my residency. But when I ended up in there and did a fellowship, I just fell in love. I just thought this was the best place to be in the hospital. And because they knew, people around me knew that I was endocrinologist. They started sending people with diabetes my way. And as I was talking to them, I realized that this was something different, that what I was experiences with the young people was not the same. I would see the patient and we will talk about what we need to do, change things certain way. They said, okay, we do that, go home, come back, nothing has changed. And we would go again, didn't we talk about this? And says, yes, 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 I'm sorry, I'll do that. And I knew that it's not that they were not believing or they were just trying to sort of ignore me. There was something else going on because they will come back and say the same thing next time. And I started, that was the 1999. There are still paper charts, right? So I went through 250 paper charts in our clinic to see that these individuals with diabetes, do they have anywhere written memory problems? Because what's happening here, I wasn't sure. And about 40% of the chart had somewhere noted, not diagnosis, but somewhere noted that there might be some memory issues. And then my husband, of course, moved to Boston, for his career, and I was interviewing, and Dr. Bill Milberg at the VA hospital. I told him, I said, there is something that I'm not quite sure what it is. It's not dementia. And he says, well, that's executive function. That's frontal lobe, which controls the behavior of stopping old behavior, starting new behavior. That's when that is affected, people have hard time. The memories, the working memory is okay. They know what you said, and they can repeat that, but they are not able to put it in the practice. And so that was that was the fascinating part. And so when I went to Martin Abramson at that time, Jocelyn's CMO, and I said, I know that there is a different way to manage this population. And I mean, there was no such thing as geriatric diabetes at the time. And I said, if you have somebody, an educator and a dietitian who would work with me, I think there is a different approach we need to do. And he says, well, we don't, but why don't you start? So that's how I sort of, that was my foot in the door. And I had a big spreadsheet, which every time I see a patient, I would screen them for mood, for memory. And that was my first publication in 2006 on my experience at the geriatric diabetes clinic developing. I did go to the pediatrics in Jocelyn because there was no model of aging. And what I realized was that the problems with pediatrics was very similar to what I was facing, where simply managing numbers in the diabetes is not enough. That if you don't look at the whole environment, you have to look at the school, how they are doing in the school, how the parents are doing, how they are doing in the sports, what is the, are they coping well, to help their diabetes get better. And similarly, on the other side, it was similar. You have to see what else is going on for the whole person. And so I took that model from the famous Jocelyn Pediatrics Clinic and developed the program there. So that was the beginning of that. And initially, it was a lot of people. Most of them had type 2 diabetes. But Jocelyn Clinic does have a significant number of adults with type 1 diabetes. And I established this clinic in 2001. And I have probably, 20 to 30% of my every clinic has older adults with type 1 diabetes who are thriving. I did not know how to, what that was till about 2010, 2015, when the technology came into the play. And that's when people were not able to manage. I still think that most of the adults who are thriving and who are doing great they are with their endocrinologists who are adult endocrinologists. But as they started seeing people struggle with them, they started pulling me in. And so I have now a lot of people who are doing great and who are, who we can change the strategy to help them manage better in the clinic. Um, I don't want to keep talking. I would love to hear what your questions are and if there is anything specific you would like to know.
I,
So
I
we
would, I
have,
would, I would just love to ask you. Maddie's got the question. What particular issues do you see facing our aging T1D population that I'm not going to address the legislation, but in terms of research right now, we can come back to that later. Um, what are you seeing as the most important things that you are addressing and the community is addressing?
So I think there are two facets to the same question. I do think that technology is very intervened with type 1 management. I mean, at every age, and that is now part of diabetes management. I think one side of that is that how do we make technology better so it can be used with all adults, including people who are aging. And aging simply means that every organ has limited compensatory power, right? I mean, whether you are, it doesn't matter with what chronic disease one is aging, but there is a change in our physiology and what is called homeostenosis, where a body's ability to compensate for each other organs is sort of limited. So how do we make technology better so that every individual, even at every age, can use that? The other side of that is that if the person who is managing the diabetes for decades and doing technology fine, if they happen to have a condition now that is interfering with their ability to do so, what are the other strategies that we can find or we can deploy that would make them continue to do better with their diabetes without making their life difficult? That makes sense?
Yeah, so if I showed up in your clinic
Yeah.
joyfully, uh, where would we start? What if I were to see a geriatrician? I'm
Yeah.
71. How does this all begin?
Yeah. So one of the things that I do differently for anyone who walks into my clinic is that I look at what else is going on, right? Diabetes is one part of you, but you are a whole person, right? So it is, and some of the things we know are not traditionally sort of intuitively thought about with diabetes, but they do impact person's ability to take care of them. For example, the example I gave you about the executive dysfunction, if somebody does not have any, if they are doing well and with a few comorbid condition, nobody would know that. They can independently live. There is nothing that would show that they have any problem. But when you give them tasks that are very complex, that's when then the problem comes up and they are not able to do that. So I typically make sure that and screening is the best way to do that, but a lot of times we don't have time or personnel to do that. But and get an idea about person's cognitive ability, functional ability, what is their support system, where are they living, who's managing their day-to-day activities, do they need any help in activities that would tell me that how much more complex regimen the person can have. And then before we start anything, what is their wish? What do they think about their diabetes? Do they think? I have had patients whose numbers were perfect, but when I asked, that things look great. I mean, do you need me to do anything? And the wife started crying because they said the entire life is diabetes, and he just doesn't do anything else. So it's about what a person wants. So I look at the whole thing, and then we decide what is the best goals and the strategy that the person, and they may not need any changes. If they're doing great, I have no reason to change anything.
Okay, I do have a question
The
about.
one thing though, I would say that especially for individuals who come in with type 1 diabetes, and I hear this all the time from other physicians as well, that it's very difficult to make the changes, because I know that you know your disease better than anybody else. So I make sure that I tell them that when I give my recommendation, please believe me that I'm not preaching to you. I'm not giving advice that I don't know about. You have probably gone through 10 endocrinologists and they are not surviving and you are surviving. So I have no doubt that you know this. If I see something that I might feel like would help you, I might recommend you. But if you don't take my advice, it will not hurt my feelings. There is no ego involved, simply what can help you. So I am very careful with that, especially with people with type 1 diabetes who have done, and you know what you go through. It's amazing.
Well, that we're still alive means we have
Yeah,
managed well, and we have
yeah,
those skills to order
to
our
do so.
supplies and
Yeah,
see our caregivers.
absolutely.
I'm curious about what changes happen in our bodies having to do with hypo and hyperglycemia. It seems different to me.
Yeah. So for hypoglycemia, it is, there are, the changes in the neurogly when there is a hypoglycemia, typically the adrenergic system gets activated. So when you are younger, where hypoglycemia, you start getting palpitation, sweating, tremors, and those things are the first signs. As we get older, sometimes this adrenergic response is blunted, and so people do not get these warning signs in that fashion, and it might. The second stage is neuroglycopenic. That's a brain feeling low blood sugar, and then you start getting confusion, or people pass out and so forth. And as we get older, those symptoms sometimes become the primary symptoms, so-called hypoglycemic unawareness. And so that is what the worrisome part is. Sometimes people say, I don't feel it, and I said, that's what worries me. I mean, fortunately, we have phenomenal tools now that now can warn us with the alarms. And many a times when people with type 2 diabetes, and they say, why do I need that? And I said, for safety. That's, if you are on complex insulin injections, I just want you to be safe if you don't want it for anything else. But that is one. With hyperglycemia, there is not a specific, any specific change physiological, as far as we do have a, over a period of time, the duration of diabetes can impact the complications, which, along with the age-related complications, everybody as we age have some other common comorbidities, age-related comorbidities, and that can be additive.
So, I've noticed a bit when I have a hypoglycemia that it takes a more, it's slower to respond.
Yeah.
Why
Hypoglycemia, you mean?
hypo? Yeah. Why
Yeah.
is that?
Well, so I whether and slower to respond with the oral, you mean?
Yes. Mhm.
Yeah. And so the neuropathy, and we know that there are two types of neuropathy. There is a autonomic neuropathy, and there is a, the peripheral neuropathy that we think about, which causes sensory issues and problems with motor issues sometimes. That is one type of nervous system that is affected by diabetes. Autonomic neuropathy is affection of the nerves that supply body organs, including your gut, your heart, your nervous system. So those are, when that is affected, that's what causes the gastroparesis, absorption issues. And many times you see that even in normal aging, in the sense, not what I mean normal by it's with people without diabetes, they're aging, there are issues with absorption, delay in absorption. If a medication like GLP-1 can in fact exacerbate that, because it's supposed to even further delay the absorption, gastric absorption. And so then when you take your medicine, that takes a while to absorb and get into the system, not medicine, food or juice or glucose tablets. and there is a delayed response to getting the blood sugar higher. And then what happens is people tend to overcorrect because it's worrisome. So a lot of times in those circumstances, I would tell them to keep their low alarm a little bit high, so that gives them time. If the arrow is still going down, then gives them time to take something, so they don't have to overcorrect, because you can wait till it after treating that, so you don't have to keep treating that.
Got it. And that's triggering a bunch of questions about gastroparesis and digestive issues. Could you just speak to that? I'm just looking at any suggestions you have regarding ways of eating, and not just medicine, but other options to help with slow digestion?
The slow digest. I mean, there are different ways one could. I don't know if medical intervention, and Nancy, you can chime in if you have any suggestions on that. I mean, in metoclopramide, Reglan, or even sometimes erythromycin, we used to use that. We don't really use that as much, uh, for as a medical. There is no specific medications for that. Smaller meals, and as I said, I don't want to preach, because I know you guys know this better than I do, that how do you manage your food so that it without having a larger boluses, so it sort of moves along. Do you have any, Nancy, do you have any suggestions on that? I'm not sure if I have any other tricks for that.
I think I can jump in to say we're going to plan a program on gastroparesis. We've done that in the past, and I'll share that in our social media so that you can see.
Do you know did they have
There,
any suggestions?
there are certain diets that can be followed. There are
Diets,
certain
yeah. Yeah.
medications that help with motility, and it's helpful to be with a team that actually understands
What's
this
with
issue.
that?
Yeah,
Absolutely.
yeah.
Yeah.
So
Yeah.
we'll probably cover that a little bit later. But there's a really interesting question. I hadn't thought about this. Are you finding different outcomes for people diagnosed with type 1 as children versus those diagnosed as young adults or later in life?
So we did actually look at that does the duration of type 1 diabetes matter? And it's, I think some of the comorbidities or complications can be present in or have a higher prevalence when you have diabetes for longer duration. But and then other issues like the neuropathy, autonomic neuropathy, and they tend to be higher when you have diabetes for a longer duration of time. With people who are diagnosed at a later age, they seem to have less problem with that. But other than that, they it just having the disease longer, that's with the rate of complications that comes along with that.
Okay. Question about, do you routinely evaluate cardiac situations or kidney or neuropathy? Do you routinely do that with your older patients?
So the kidneys, yes, we keep an eye on kidneys on a very routine basis. In cardiac conditions, in general, I also do primary care geriatrics. So it's I have one clinic where I do primary care geriatrics, one clinic where I do consultants. I am more aware of asymptomatic, if I feel like there are symptoms suggestive of cardiac disease, but routinely we don't get all the people with diabetes through cardiac workup. That has not shown to be effective if they are not symptomatic or there is no signs of that. And neuropathy, yes. I do tell my patients that it doesn't matter whether you have neuropathy or not. The risk is always there. So some of the things where you look at your feet, you feel, feeling the pulse and making sure that they have good pulse, and checking feet every night and keeping it moisturized, and no cracks in the skin. Skin is the best barrier, and so forth. So education works the most, because whether they have neuropathy or not, it's important that the feet are looked at by the patients themselves on a regular basis.
Okay. These are all really interesting questions. Under what circumstances might you recommend multiple daily injections over the developing technologies?
Um, as I said, I do have, so technology is phenomenal, but it is not quite yet to a point where it is that there is no user input needed. And I tend to have a patient referred to me who are actually having problems. So if patient people start having problem with their AID or pumps, and you see that they are struggling with that, and you do everything. We have the phenomenal educators, so and lot of this educator know pump even personally. They know how to do that, and we really don't take that lightly, because people who are used to using technology do not want to give that up, and that's one of the hard thing to do. But I'll give you one example, was that one of the patient had, and just could not, she was going out with the aide, and husband was not always with her, and it was high depending, nobody really knew when she was taking boluses, and those were the time when there were caregivers with her all the time, and they were all extremely stressed, not just the patient but everybody. And we changed it over to the MDI, and somebody else was helping her. She took, she was off that responsibility, but that was when she had pretty significant cognitive decline. So that is different, but otherwise it's other people that I have taken off sometimes is when they are in the hospital with a stroke and something like that, and then they are not able to manage the way they used to. Again, this happens to everybody who gets that, but the complexity of managing an AID or pump is so much that unless somebody is helping them, it's hard to let it go on an individual person. It becomes more of a burden than something that helps them. But again, we talk extensively. Shared decision making is a huge part of managing type 1 diabetes. And unless they are at harm to themselves, we just let it be and see. I do think, though, that the newer pumps and AIDs are going to be much easier. If we don't need a whole lot of input from the user, then the biggest problem remains is troubleshooting. And what happens when something happens and they can't figure out what to do now. So that's about the bigger problem. But otherwise, it's really very hopeful. We are getting better and better systems, and at some point we'll be able to use it without input from the user at all.
So the issue will be site changes
Yeah,
and making sure CGMs are in place. Do
yeah.
you ha have any sense of how that starts to get addressed in terms of the care team that surrounds the patient?
It's part of it is, I mean, even if, some of the issues that we have faced in the past is that one was where the patient was unable to change the pod, and it was hard, and somebody would come in every 3 days, but then she would go and eat something. Some days she would bolus, some days she would not bolus. So there are like a yellow wall on some days it will be low. And those are the times when you say, okay, just don't do anything, don't bolus, just, and And those are the times when you see if you can lock it. That's another thing. Now that you can, if you can lock it and somebody cannot keep on pushing on to get themselves bolus, that helps, right? So those are the minor changes that are happening that are really helping. Most people don't have problem with CGMs now. They are so smaller, so much smaller, and the people who peel it off and throw it away are not usually in the type 1 space because they are used to that. So that's not a problem that I face in type 1 space. But I think if you don't have to give bolus, if there is a minor, because sometimes doing multiple bolus through the day is part of the psyche, right? It's in the hard drive. And so when there is a mild cognitive impairment, they keep bolusing, and that becomes a bigger problem. So but if you can lock it, and that is another trick that has helped. So it's getting better step at a time. uh,
And I think there's the issue of caregivers and who is there for us. And is there much research on how we start to address the need for us to access allied health people?
The allied health people, meaning like visiting nurses and those kind of things.
Mhm.
Well, we have a lot of work to do on that because nobody knows that disease. I mean, your primary care, your nurses, unless you are in a diabetes center, people don't know this disease. And I worry about that part of it. I think visiting nurses don't understand the multiple MDI type 2 diabetes, but they can be hurt less quickly than someone who has type 1 diabetes. And 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 we have to educate them. We have to do something where there are people who, and every visiting nurse doesn't have to. We have wound nurses, right? The visiting nurse, they have specialty wound nurses. So let's have a specialty type 1 nurses where they know what to do, what to look for, and how to manage, troubleshooting. If we can get somebody to get into the house and say, why is this pump beeping? Why is the blood sugars remaining high? Is there a tube problem? Is there a insertion size problem? What's happening? If somebody can get in, that would save so much trouble, and let people continue on the technology.
Yeah, I think Nancy was talking to me about that, about having a troubleshooting booklet or something that
Yeah.
can teach some of these caregivers. There's an issue that comes up a lot, and I didn't understand it initially, is physical geography, where on your body you've been taking injections or infusion sets or CGM for years and years and years, and it does damage to the skin, and skin ages and gets thinner.
I
Is
know.
there research on?
Not enough. You know this research. I know you talked to all Hirsch about that during the meeting, and they have been, there are, uh, I think the whole generation that is now aging, it's a very unique set of population. We have not seen we don't know how to handle some of the things that come with that aging. I fortunately have not seen as that much of a problem in the population I see. And as I told you, we just finished study on type 1, 165 older adults with type 1 diabetes over age of 65. And they usually have been doing pretty well with real estate, as you call it, on this how to do that. They may not have been using it for that long, though, to tell you the truth, because you guys are innovators. You are the trendsetters, and so the some of the issues that you face over prolonged period of time by using that, they have not been I have not seen it in that population. It could be also the one that you are saying about people who have diabetes since very young age versus people who develop it in their 30s and 40s even, and that's even different. Um, but I know they are working on it. I know Hirsch is working on that, and hopefully we'll find out soon how to manage that.
That was great. I'm curious about the incidence of long-term T1Ds developing insulin resistance, and then the use of SGLT2s and GLP-1s. Is that a frequent thing?
Uh, Again, I have not seen that. I worry a little bit about so GLP-1 is we seem to be using more. Uh, Again, in my clinic, I tend to be a couple of steps behind the cutting edge because I don't want to try something new without knowing what's happening to everybody else. Because we don't have a whole lot of, we don't have a safety zone that younger people have. And if we have somebody who gets into trouble, that can go poor way very quickly. SGLT2 inhibitors are a little different. I even in type 2 older adults, I worry a little bit about with that euglycemic decay that can develop in frailer the person is more likely, and we are seeing more and more of those. So they end up with acidosis in the hospital, and that's why with type 1. So unless you have a specifically insulin resistance, and do you see that among yourself a whole lot about insulin resistance?
I do, and among my friends, I do. And when they go on a GLP-1, they smooth out
Smooth
the.
out. Yeah. Yeah, GLP-1, I think that I have seen that. As I said, I don't use a whole lot because typically the people I see, I have a lot more issues going on. So it's not something that I jump at, but it makes sense physiologically, and I've seen people, doing better with GLP-1, and even, but then again, the gastroparesis and the decrease in, the appetite and weight loss, and so when you go to the other side, the spectrum, I'm the only one at Jocelyn who worries about weight loss. That I don't, I worry about somebody losing weight, and then if they get sick and get further weight loss, that becomes a bigger problem uh, than higher weight. So part of it is balancing the comorbidities. It's a competing comorbidities, so called, and at this point, most of the people are not without some of that, and I worry about that. The cardioprotective and renoprotective effects are the more important that I would say that I would put people on for with type 1 for on GLP-1 and SGLT2 inhibitors. If I feel comfortable with SGLT2 inhibitors, GLP-1, I feel comfortable to put, and some of them are on that I see them, but I don't necessarily jump at that.
Oh, interesting. This is an interesting question. I'm curious about this. Are there complications that, if you haven't developed them by a certain age or a certain length of time with T1D, are you in the clear, so to speak, or
Yeah,
likely
yeah.
to develop them?
And George King had, this 50-year medalist program that if you haven't developed that kidney issues, then you are probably protected against that. So I think that is the whole idea about the genetic versus environmental versus epigenetics. The whole thing about that. I do think though that those that is interesting to me, that how the certain complications are not, but then age is still there, right? So you still want to make sure that you are screening them and doing all the preventive stuff for that, because uh, the aging aging component will be still requiring caution with that.
Got it. Let me just take a look here. There's some questions. I think this is probably not quite in your domain, but in terms of diabetes management, of getting your supplies, of getting your prior authorizations, from your perspective, are you seeing research on how we do better with this and help our community?
Yeah, and I think, I mean, as you say, the good part about being in a tertiary care diabetes center is that you have so many. So we have a technology team that actually handles all the. So I get a parachute, email that I sign them because somebody else puts all the paperwork in. The bad part about that is that then I don't know what exactly goes into the process. But I do think that we are, to the advocacy about that it should not be 5 years to change, and how can we change that because new technology comes along, you are using something and now you need to do something differently. How can we avoid, that you are stuck on something like that. But and I think with the again, as you say, this is not my area of expertise, but what I understand and learn from my colleagues is that if you have the pharmacy benefit versus the DME, and how you can sort of change if there is more of a pharmacy benefit. But the educators, if any of you have any question or problem about that, write to me. I can find you an answer because we have some phenomenal people at Jocelyn who know a whole lot of more about this. The educators are fantastic, and I can find answer for you. I don't know, but I can certainly find it for you.
I've heard a discussion in your groups about loosening up on control, time and range. Uh, can you just talk about that a little bit? Because it's really hard for people who've been living with the word
Yeah.
control
Yeah.
to give up
No, I
control.
know. I think, and that's what, as I was saying, when I see that people with type 1 diabetes, that I tell them that the very fact that one survives with this disease is by having the tight control. So it's not it's very logical that when somebody starts talking about loosening control, that is, that doesn't sit well with you. That makes sense. But the idea is that if we say that anything, the why was the control important, because you were given very specific reason that we want to avoid complications, that you want to avoid DKA, that how that works. At some point, the treatment of the disease becomes more harmful than disease itself. And that's the only reason why somebody would say that we need to change the strategy. I still have a problem saying that it's not loosening the control, because by no means you have to let go of the control. It is changing the strategy. And we had a workshop, and when I sent that to Joanne, and she said that she had a gut reaction to our agenda. But and I would say that if you read that output from that workshop on, we actually changed the term from deprescribing to realignment, because deprescribing is a very common, very actually revered word in geriatric medicine, because we think that by doing so, we are decreasing the burden from the patient. We could deprescribe or de-intensify things like narcotics or antipsychotics or medications that are causing a side effect to the person. In diabetes, you cannot deprescribe. That it is not like you can take it off. Even at any point in life, you can't take people off insulin if they have type 1 diabetes. what we do want to do is realign only people who are having problems. And so we wanted to make sure that the first line is that in all older adults with diabetes, continue according to guidelines. You don't really have to go around doing things to people who are doing well. But if they start having problem, then we have that 4S structure. The first S is to look for the signs and symptoms and triggers. What are the symptoms that suggest that the person is having problem? Whether it's as simple as not sleeping well suddenly. Are they getting hypoglycemia? If they're getting more confusion, is that hypoglycemia? So things like that. So identify that. The second S is shared decision making. So before you do anything, talk to the patient and tell them why you are thinking what you are thinking, and to make sure that realignment does not mean giving up control. It means that we realign it so that you are safely getting your, the you are safer, and the strategy is better for whether it's quality of life or safety. And then set and reset goals, and then simplify the regimen. And Joanne, I sent you that paper from Diabetes Care. And what we did was in there, and we only take people who are having hypoglycemia. So baseline characteristic was people who were with type 1 diabetes, who were having multiple hypoglycemia or wide excursions, or they were having this reactive pattern where, and and based on and the overall health. So the idea for, we have this framework for people with type 2 diabetes, that you can be in a good health, intermediate health, or poor health. The way you decide where it is not by age in number, but by three variables. One is cognitive function, one is functional status, and one is comorbidity. So if the cognitive function is intact, you don't need any help, you are functionally independent, and you have few comorbidities, high blood pressure, cholesterol, something simple, then you are in a healthy category. The poor category is people who are in a long-term care, or who have end-stage diseases, and those are in poor. Everybody else with little bit of issues with cognition or dependency on caregivers, or conditions that interfere with their ability to do self-care, they are in the intermediate. And we opened up the time the goal for time in range. So instead of 70 to 140 or 180 for everybody, the healthy is, we put it up a little bit of 90 to 180, and then 100 to 200, and 100 to 250. What Opening it up so that their goal is a little bit wider. What we saw at the end of the study was that their time in range was better, because they were not constantly chasing that. And we could decrease hypoglycemia, but we could also increase time in range. So I think we don't have to give up the control by saying that we are going to change the strategy. And that's what I wanted to really stress on, that deprescribing was a bad word. That was not what we were trying to do. Even after saying all these things, and I understand, because this is very personal, and I got an ATTD, somebody said that, do you think, talking about deprescribing, it's easy to die of decay? And I said, oh my God, I mean, that would not be a treatment. Uh, that is not medicine. That is not what this is about. This is about making sure that the treatment of the disease is not going to hurt you more than what disease has done.
I think it's really interesting that if you widen the range, you get
Yeah,
better
it
results.
tightened. People got tighter by giving them bigger area to work on. And again, this is not people who are doing well. We are not going to change that. This is only when they are starting to struggle. And then you say, how do we make this easier and safer?
That makes perfect sense to me now. Thank you very much, Amanda. A question about the Joslin Medalist Cognitive Study. There's a few people I think on here who are in the program, and they were asked to take memory tests. Are you familiar with that part of?
Yeah, I actually I'm not part of it. George King runs it, and he does it with his team. But I did you I'm sure he got, because they were asking us what we tend to do. And MOCA, is that the test that you took? Is that the one we are talking about?
Yeah, I think it's Gloria. You can unmute and share if you'd like.
I didn't take the test, but I believe it was a series of um, questions and memory type things. I
Yeah.
didn't happen to take it myself, but
Yeah. So typically, so what we have found in our previous study is that when you talk to, it's very difficult to identify mild cognitive impairment by talking to to patients, unless you screen for that. And the mild cognitive impairment, by definition, is that there is some decline, but it is not interfering with your day-to-day life. So you are able to do everything you need to do, but you know that there is something, there is some decline. And which organ? I mean, brain is just an organ, right? Brain is not something different than our heart or lungs or kidneys. And same, the blood supply and the nerve supply and the hormones. So there is some decline with aging that occurs in every organ. And the idea, typically in our geriatric clinic, we do this every year, not MOCA, not all the whole thing, but the screening test every year as part of annual wellness visit, to see whether we see any signal that there is any problems developing. The reason is twofold. One is that if we think that this is now getting to a point where the person is in danger, and even in people with mild cognitive impairment, I tell them that two things I want some another pair of eye on is finances and medications, because there are a lot of bad stuff that happens to people who are, they are fine, they're living alone, they're managing fine, but that mild cognitive impairment can put them at higher risk of these frauds and hacks. And then medication, if you forget, or that might create a sort of spiral down on that. And the second thing is, we have more and more now medications available. We have now tests for Alzheimer's disease. We have now treatments that are coming along, and soon there will be something that you can prevent it if you further decline. So we need to know so we can treat it just like any other disease and prevent people from needing further dependency, right? That's most of the people is worried about, me and everybody else, that we don't want to be dependent.
I was kind of holding on the issues of cognitive decline only because the statistics are a little frightening when you hear them as a T1D. And we want to do a program on that very specifically. But the question just came up. Do you recommend referrals for a baseline psychoneurological evaluation?
Yeah. If you start having a problem, again, two reasons why I would do that in anybody. One is that patient themselves are very worried that, I forget my keys when I don't know where I leave it, or I go to another room and I see that, what I came to, and this is probably happening to people all their life. But now it really bothersome. And I said, you know what, get a baseline so that you get out of this fear, so that every time you walk into the room and you forget why you came there, you are not like, uh-oh, now it goes again. So that is one. And the second thing is that a lot of people who are highly educated, and so when you have a decline in cognition, there is a threshold. So it takes a long time for them to get there. And so if somebody is very educated and they are making mistake that I think are not something that they should be doing, I get them the neuropsych testing, because for them, that error, which might be normal for other people, is not, the mathematicians should not be making that kind of error. And so then, because they would pass the screening test, that's not going to tell me anything. But if they have it, I want to follow that and treat them before we get into trouble.
That's fabulous. All right, I'm going to come back to an issue of advocacy, because part of what we're doing in T1D to 100 is look to where we can get our voice heard, particularly in hospital care, dealing with the medical community. And Maddie just asked about advocacy at Joslin, and are you familiar with what is going on within Joslin?
You mean if Jocelyn has advocacy
Efforts and yeah,
efforts?
yeah.
I do not know. I can find out and let you know. I know at ADA, I have been now working with them in several different areas. And in fact, one of the time I got a call from the legal department at ADA asking me, what is what are the criterias for people with type 1 diabetes in the long-term care, because somebody was refused and they said, is that legal? And so then I had to explain to them, what is happening there. And so we have been, there is a working group and we are working on that. At Jocelyn, I do not believe there is a specific advocacy effort, particularly, but I would say that is on the provider side. I know there are a lot of phenomenal patients who are involved, and there might be, that's why I'm saying that let me check with them, because there might be an effort that is going through that I'm not aware of.
Got it. Thank you. One of the fears we all have is being in the hospital, having people take care of us who really do not understand our disease. Do you have one or two pieces of advice, and I am putting you on the spot, that we can take away and accomplish or do that would make us safer in a hospital setting?
Yeah, this is this is not medical or academic. This is really my personal opinion here. I think even even on the other, I mean, there are so many hands that touch an individual who is admitted, that to make sure that there is no error, and there is no space for error when someone with type 1 diabetes is admitted to the hospital. I know that if I say that it would be good to have somebody with you, but that's not always practical. It's not like there is a way to do that. But at the same time, a pair of eye, that when you are not able to advocate for yourself and you are not feeling well, somebody there to advocate for you is probably the safest way. I know that that's not a right answer, that's not possible in many ways. But we are just that bad. I mean, in the sense that people don't know how to manage this disease in the hospital. And
Yeah,
and
I think what I keep saying is we need to advocate the best way we can. We need to say to everyone who walks in the room, I have type 1 diabetes,
yeah.
or wear a wristband that says that if we can't speak, um, because there is so much confusion and they're not focused on that when they're taking care of some other problem.
Yeah.
But I
I
didn't.
wonder if Joanne, if you can have like some basics written on a paper, which says that I have type 1 diabetes. I cannot my insulin cannot be held. I mean, some basic safety ones, right? That's what worries me, that they would hold insulin because you are low, something like that, right? So I have to have insulin. If you have any question, here is my doctor's phone number, or here is my nurse's phone number. Like 5 or 6, not too many that they would not read, but 6 points that says that this cannot happen. And at the end of it, that if you want any further information, or you don't believe this, please call this number or something like that. Because saying type 1 doesn't make that safer. That's my worry. That you have to have a team, that a nurse or the LPN or the aide that knows what type 1 is. That's a problem. But the point
Okay,
is that
anyone?
do not hold my insulin, or don't give me a house scale, which is
A
meant
sliding
for,
scale, yeah.
yeah.
Anyone who's on my T1D volunteer list, who wants to make the list, just send me an email. We'll put that on the website so that there's something that can sit on the nightstand and be
The
there if you.
five points, no more than 5 points in bold letters, that cannot happen, something to that effect.
And I want to just mention the discussion has gone on in the chat, and I'll send you a copy of that. That your term realignment is needed is wonderful. Everyone is actually resonating with this, saying yes, we realign so
Yeah,
often in a day, a week, a year, a
yeah,
life, constantly.
yeah,
So
yeah, yeah.
we like the term, Meta. Thank you.
That's we spent actually out of 2-day workshop, and Nancy, I don't think you were there. You had something. Oh, you were there. You were there.
Yeah, I was there.
You spent half day, right? With simply because nobody could agree on one word, and we finally landed on this, because it says actually that is exactly what we are doing. That we are really not stopping anything. People didn't want to come away from deprescribing, because that's the term that has been used. So if you do a PubMed search, realignment wouldn't give you anything, but deprescribing would get you the information. So we added that's a way to deprescribe. Realignment is the way to. So we kind of got into, but yeah, it's I could see that my geriatrician colleagues and my endocrinologist colleagues were never this far apart on any issue as the deprescribing. They did not agree to at all. So hopefully this will bring them closer to that.
I think it's wonderful, and I can feel several of these people on the call just kind of go, yes, we can live with that one.
Yeah.
Um,
And
yeah.
only if people are having problem. That's another thing that we have to really underline, that this is not needed for all older adults. It's like, aging and deprescribing. That it's not something that goes with aging. It goes with having difficulty with your current regimen. That's the only time you have to then think differently. But otherwise, if things are going well, don't touch it. We do not need to touch it.
We're happy now. We're a lot calmer. Thank you very
Oof,
much.
as a geriatrician, right?
And all of you on the call, you'll also probably meet Nancy Allen in another event where we're discussing what we need to talk about having to do with cognitive issues, which are so concerning to us. Even if we don't have it, we know some of the concerns. So that'll be coming up in the future. Dr. Munshi, thank you so much for your
Oh,
time.
my pleasure. It's truly pleasure.
I will continue to
Yeah.
send you the questions, and I'll let you know what the community is saying.
And again, if you need anything that I can help you with, I may tell you that I don't know, because there is a lot that, the technology part is something that I am still getting to know, because again, as I told you, I see people who are struggling. So that's what and how do I make it better? But there is a lot of hope. There is a lot of hope. I hope about people being able to use technology, hope about cognitive function and how we can prevent it and how we can manage that. and rest of the hospital and long-term care will get there. We'll find a way to make it better.
Thank you. Thank you for your time. Thank you for caring about our
Of course,
concerns. It makes us feel a lot safer, and thank you for your evening.
You're very welcome. It's a pleasure to meet you all. Take
Bye-bye.
care.